Okay, good evening, everyone. It's such an honor to be here. My name is Danladi, and I'll be talking about the smooth criminal. I was having a Michael Jackson week when I came up with this title, so yeah. But it's themed from the fact that that person that does something bad and gets away with it and still looks cool. So over the years, we've had a lot of patients develop kidney disease, and we really don't know why. That's why I titled this "The Smooth Criminal." So a little about me. My name is Danladi. I'm a consultant nephrologist. I'm presently the head of dialysis at the Federal Medical Centre Ebute-Metta. Essentially, what I do is I treat patients with kidney disease. I have a specific interest in looking after patients after their kidneys have failed and also preventing people's kidneys from failing. Been privileged to have clinical experience across Nigeria, UK, and Ghana. And I'm one of the investigators in the ongoing Amplitude trial, which is being carried out across the world, which has yielded some really interesting information, which I would like to share with everyone today. So I won't bore you with the table of contents. So interestingly, I've been interacting with a lot of people recently, and when I ask people kidneys, what comes to mind? And I want everybody to ask themselves this question. Just ask yourself, when you hear kidney, what comes to mind? And when I was asking people, especially the younger population, when I asked them, when I say kidney, what comes to mind? And interestingly, this is what I got. Most young people thought of suya and how they like kidney is the nicest part of suya. And I personally agree. The other response I got from much older people when I said kidney to them was dialysis and how they knew people who had done dialysis and those people didn't do so well. Then when I asked the Gen Zs about kidneys, guess what they said? Most of them were talking about donating their kidneys and how much people are willing to pay. So they very young people think it's a source of money that you can donate your kidney and make money from it. So, but really, what are these kidneys? So the kidneys look just like this. I have a tiny kidney model in my hand. And what they do is the kidney filters blood. It is located somewhere in the back, right? And there are two of them. Most or almost everyone is born with two kidneys. And what the kidneys do, the primary function of the kidney is to filter waste. So the blood flows into the kidneys, flows into one of these guys. And when the blood flows in, the kidney filters this blood. And the waste comes out on the other side, which I'm trying to demonstrate here. The waste comes out from this other side as urine. So blood comes in, the kidney filters it, the waste goes out as urine. So essentially, you can see in there the filters and everything in the kidney. So that's what the kidney does. But the kidney is like a Nigerian, right? All Nigerians have side hustle. Like my side hustle, I'm a farmer. So if you want yam, just call me. The kidney also has a side hustle. The side hustle of the kidney is it helps the body to make blood. So when we have patients whose kidneys are not working too well, one of the things that tends to happen is their blood levels start to go low, and sometimes you need to transfuse them. But guess what? The kidney has another side hustle, which it helps the body with calcium, and it therefore forming strong bones. Interestingly, there's another side hustle which is related to our topic today. Another side hustle of the kidney is that it helps control blood pressure. So once someone's kidney is not working too well, there is a chance that the patient's blood pressure starts to go up. In fact, kidney disease is a major source of hypertension. So when you have a young person who has hypertension, maybe you see someone who is 19 hypertensive already, 25 hypertensive, you need to check that person's kidneys because a lot of times when these young people have hypertension at a young age, it means that the kidneys are not okay and they're not regulating the blood pressure well. So side hustle of the kidney is also remember that the kidney controls blood pressure. And that should also tell you that the people who usually treat hypertension in hospitals are nephrologists, such as myself, are not cardiologists like most people think. So why are these kidneys so important? When the kidneys fail, it's an issue. You need to put the person on a machine to support the person's kidney function. And one of the things why nephrologists are so popular now, I tell most people that I have more patients than cardiologists. In fact, I have more patients than any other consultant in the hospital where I work. And the numbers are really staggering. So if someone's kidney has an issue, The person will need dialysis, basically to take over the function of the kidney temporarily. And this is some data from Nigeria. Nigeria, we now have a renal registry, and I'll just go through some of the data where someone's kidney does not fail, should not fail. So some of the information we found out is that people have kidney diseases more in the dry season than in the wet season. So we've attributed that to dehydration. So everybody should have a glass of water or a bottle of water. I have mine here. So please move around the bottle of water. We've seen that kidney failure occurs in dry season. So that's data from Nigeria. And it tends to affect, kidney failure tends to affect people in their most productive years, between 40 and 60. So I guess we are the target population for kidney disease as well. So we should all be careful. I'll quickly run through survival for people who have kidney failure. So when we looked at people who had kidney failure and needed dialysis, guess what? If we look at mortality, how many of these people were alive when we looked at the numbers? After 1 year, only 67% of the people were alive after 1 year. So if someone starts dialysis now from kidney failure, the chances that the person will be alive in 1 year is 67%, 68% roughly in Nigeria. Guess the chances of the person being alive in 2 years? 24%. So if someone has kidney failure, the chances that the person will still be alive in Nigeria after 2 years is 24%. So it's really, really important that we catch these people early and prevent them from getting to the point where they need kidney failure. Sorry, they need dialysis or develop kidney failure. So this is some data that shows the prevalence of kidney disease in Nigeria. We have up to almost a quarter of our population having some form of kidney disease, which is a lot. And I personally believe this is underreported. And so I believe the numbers are even more than that personally. So who gets this kidney failure? There is evidence that kidney failure, like most illnesses, tend to affect Black people. And the data from America shows this, that people of African American descent account for 30% of kidney failure cases, and the Black American population in America is just 13%. And in the UK, those people who need renal replacement therapy, 8.1% of them are Black, but these guys only take up only 4% of the general population. And interestingly, we found out that the kidney failure occurs younger in Blacks than it does in other populations. So that means we are a target population and we should all be scared, because kidney failure seems to be coming for Black people, and it's coming for them in their prime. There is also data out there that shows that most times when people develop kidney failure, we just don't know what causes it. And you can see from the data from Europe shows that as much as 28% of the time, we don't know what causes it. And even ranges up to 50%, we just say the person has CGN, unknown etiology, this person has kidney failure. And up to 10% and 70% pediatric populations, we've been able, because of genetics becoming more popular, we found that up to 70% of patients may have a genetic cause of kidney failure. So a lot of work has been done, and late 90s, 2000s, and now we found out an illness which I like to call the sickle cell of the kidneys. I'm sure we've all heard of sickle cell disease, and there's a similar illness that occurs in the kidneys. So I'd like to call it the sickle cell of the kidneys. Right? So a little about sickle cell. What happens in sickle cell disease is that there was an adaptation in humans to protect them from malaria. So there's a part of the cells of the red blood cell that sort of changed to make it make the environment bad for malaria. So because of that, malaria couldn't survive in this red blood cell. So normally your cells should be AA. But when the adaptation occurred, an S was traded for that A. And so when we started developing AS, the chances of these people developing malaria and dying from malaria became less, as you can see on the right. You can see that AA chances is quite high from dying from severe malaria. But once that S mutation came up, which protected from severe malaria, you can see the chance of mortality in that red circle reduced. But when that mutation becomes excessive, and then you have the SS variant, or when people become SS and we call them sickle cell, it made the cells just friable, which was one of, if I may call it, a downside or a side effect to that adaptation was that when that adaptation was overexpressed, the cells became fragile. And so these people are normal, but once they're exposed to stress, their cells just start to break down and they fall really sick. So an adaptation protected from malaria, but resulted in very, very friable, very weak cells that once exposed to any kind of stress will start to, is easily damaged. A similar phenomenon occurred in the kidney. So, but this time with trypanosomiasis. So there's something called the APOL1 gene, right? And that APOL1 gene protects from sleeping sickness, trypanosomiasis, right? But the trypanosoma, with time, developed an adaptation to protect itself from that APOL1 gene, which is what's in the middle here. So the APOL1 gene in the rhodensiense variant, which is the organism which causes trypanosomiasis, adapted to this APOL1 gene and prevented the APOL1 gene from destroying it. So this variant of sleeping sickness was able to evade the immune system, the APOL1 gene. And then humans adapted to this by changing the configuration of the APOL1 gene, which is normally G0, G0. Humans adapted to form a G1 and G2. So people can now be G0, G1, G0, G2, 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 G1, G1, whichever. That adaptation protected from trypanosomiasis. It gave humans, but then the side effects, like sickle cell had side effects in forming fragile cells. This resulted in fragile kidneys. So once we had got that protection from trypanosomiasis, the cost we had to pay was to have fragile kidneys. And what this tends to do, which I'm trying to display on the slide, is that it causes the cells in the kidneys to leak potassium. And then that results in several steps and several mechanisms, which eventually destroys the kidneys. So there is a two-hit mechanism to this, which I'll show shortly. Let me quickly show the two-hit mechanism, in which first you have the mutation. And then once your kidneys are weak from having that mutation, the next thing that happens is whenever you get a slight infection, dehydration, the kidneys fill very rapidly. And I'll show that in some of my slides coming up. So, okay, so this is the second hit mechanism. You can see the first hit is having a mutation. The second hit is any infection or anything. So someone who has the APOL1 gene mutation will be fine. But once the person has anything, is viral infection, in diarrhea, the person has a chance to just develop kidney failure very rapidly. And that's what the second hit hypothesis is. So interestingly, the APOL1 gene is, guess where it's most common? I said these things are most common in Black people. And if you are looking for a Black person on the planet, guess the one place to look will be Nigeria. And studies that we've done, genetic studies that we've done across Nigeria, we found out that up to 25% of Nigerians have the APOL1 gene mutation. In fact, the data shows that in the east of Nigeria, it's as high as 50% of people having this gene mutation. And like I said, having the mutation does not mean you develop kidney failure, but it means that the person's kidneys are fragile and can fail easily when stressed. So a little about how the mutation works. Generally, it's inherited once someone has a mutation. So like what happens in sickle cell, you get one of the genes from your father and one from the mother. So like what I have at the top now, I have A plus A. So if you get A from your father and you get A from your mother, you become AA. If you get A from one of your parents and S from the other parent, you become AS, and that's a carrier state. But if you get S from both, then you become SS, and that's the disease state. A similar thing occurs in the APOL1 gene. So the normal thing you should get is you should get G0 and G0 from both your parents, and you have the normal G0, G0, which is the normal thing. But when you have that mutation of either that G0 changed to G1 or G2, then you start to have a carrier state. So if you have G0, if you get G0 from your father and say you get G2 from your mother, you have G0, G2. You don't have a predisposition to kidney disease if you are G0, G2. However, if you have a G1 or G2 from either of your parents, from both your parents, then you have a problem. So if you are G1, G1, or G1, G2, or G2, G2, then you would have those friable kidneys that can easily fail under stress. And so this is just some of the data from across the world. And you can just see, I will not bore you with this. You can just see the red lines show what happens to patients who have similar illnesses and don't have the gene. So the blue line shows what happens if they don't have the APOL1 gene mutation. But you can see that the chances of their kidneys failing occurs very rapidly. You can see for this one, it occurs at 5 years. And then you can see for the patients who don't have it, you can see them going as far as 30 years without their kidney failure. So you can see there's almost a 30% reduction, and then that reduction of up to 50% in 5 years, which is significant. So anyways, you can see that the same thing on the graph on the right. Those with the APOL1 gene mutation represented in the red, you can see how rapidly their kidney function declines to those who don't have the mutation. So having the mutation causes a more rapid and more early decline in kidney disease. And this is also shown in COVID. I did some work on COVID, and one of the things you would notice is that you can see once the chances of them developing severe renal disease occurs when they have both risk alleles. That is either they are G1 or G2, or G1, G1, or G2, G2, or G1, G2. So, and this is even more data, which I won't bore you with, but you can just see that the graph generally, once someone has the APOL1 gene, you can see the chances of decline in renal function is a lot steeper or a lot sharper than you see with those who don't. So you can see that red line separating early, showing how rapidly the kidney function declines when patients have this APOL1 gene mutation. And the similar thing occurs in diabetes. If someone has diabetes and has the APOL1 gene mutation, the chances of the person's kidney failing is higher than that with if they did not have the mutation. Furthermore, we found out that this study showed that the issue is not in the blood. So one of the things they did was they gave kidneys they found out that when people have this mutation, right, and you give them and they get a kidney, say the person has a mutation, the person's kidneys have failed, and you give this person a kidney, they found out that the kidneys last long. But so that shows that it is not like there's something in the person's blood that is destroying the kidneys. It must be something intrinsic in the kidneys. So we found out that when we take out the kidneys of someone who has this mutation and give it to someone else, those kidneys fail early. So it shows that it's a factor in the kidneys and not necessarily in the blood. So having said all this and letting you all know that there's this cause of kidney disease we should all be aware of, the big issue is over the years, treating kidney disease has been really difficult. A lot of times what we do is, like we said, once the kidneys start to fail, the blood pressure goes up, is we control blood pressure. And sometimes when we can find a secondary cause, we're able to give them steroids or something to slow down progression. But generally, there isn't much we can do. The way kidney failure presents is they present with, when they do their kidney function test, there's a certain waste which the kidney is supposed to remove called creatinine, and that creatinine starts to go high. Then we say the person's kidney is not working well. But the other thing is that the kidney works like a filter, like I said earlier. We start to see things that the kidney normally should hold back in the blood seep into the urine, and that is called proteinuria. So protein in the kidney is called proteinuria, and that is also a marker of kidney disease. So after finding out this, about this APOL1 mutation resulting in kidney disease, several strategies have been used to target kidney disease, and these are some of the strategies. I won't bore you with all of them. But what at Vertex we've done is that we've targeted that channel from which the potassium leaks when people have that mutation, and we're able to block that channel. And so we first did this in the mice model in the preclinical trial, and we found out that, which I will show shortly. So I'll quickly just talk about clinical trials. Usually what happens when we're developing a new drug, which is what we have at Vertex, is you first do the preclinical, in which you want to be sure that it works. You see that, you take cells and you work on the cells, and then that's the preclinical. And then after you're sure it works in the lab, then you try on animal models, right? And that's also preclinical, right? So you do the lab and the animal models are preclinical. Then the first phase 0, phase 1 is you are trying this on people who don't have the disease. You want to be sure that this drug is safe. You want to know the doses to use. You want to be sure there are no side effects. That's phase 1. And then in phase 2, you try it on people who have the disease you're looking for. And then in phase 3, you do it on a bigger population of disease. And then phase 4 usually is a monitoring thing. So we found out that when we tried it in animal models, basically we got mice and then we made them develop kidney disease by giving them interferon. We're not bad people now. We don't hate mice, but it's their calling. So we found out that you can see on the right is that when we gave them this molecule, VX147, it has a name now. We found out that you can see what's in the red. They were not leaking as much protein in their kidneys anymore, in their urine. So we found out that this molecule in mice reduced proteinuria by over 70%. So, and we also found out that when we tried it in the preclinical in normal people, we found out that, oh, it had really no impact on food and that it worked and it was safe and that it lasted in the blood for 16 hours. So it means you could take it once a day. Essentially, and we really not. And so we moved on to phase 2. And then our phase 2 study has been published in New England Journal of Medicine, which is probably one of the biggest journals in the world. And what we saw with the 16 patients we looked at in the phase 2 clinical trial was almost all of them, except one. So 15 out of the 16 had reductions in proteinuria. And on the average, it was more than 50%. Right? We also found out in our phase 2 clinical trial that the side effects were not serious. And so no one discontinued the medication because of side effects. So our phase 2 clinical trial got us excited about the phase 3 clinical trial, which we are still doing. So essentially, we have a molecule now that can treat kidney disease, which is common in Black people. And this trial is being done across the world, and one of the biggest sites in Nigeria. And we're lucky at FMC Ebute-Metta to be one of the sites that's conducting this trial. So if your urine is foaming, whenever you go to pee, you are seeing a lot of foam, and people are asking, oh, wow, is there soap in your urine? You may just be leaking protein in your urine. And if you're between the ages of 12 and 16, there is a chance that you should come and we'll screen you at no cost to see if you have the gene mutation, and then we can get you on this drug. So essentially, you need to be between 16 and 15, and the rest is really on us to see if you qualify to the trial. If you have another cause of kidney disease, then maybe it may not be the APOL1 mutation, and so you will not be eligible. For the doctors that may want to send us patients, is patients who have other causes of kidney disease may not be from the APOL1 mutation, and so those patients will not qualify for our trial. So these are the times we take the samples for the patients. So we regularly check these patients, and in lots of the patients, all the patients from our site that have been enrolled in this trial have had good results. The interesting thing is that it is what we call a double-blinded trial. So there are some patients who will get the drug and some patients who will get placebo. And looking at their numbers, I can almost guess the ones that are getting the placebo. So essentially, patients come in at intervals in which we do the full blood workup for them, ECGs and everything, just to be sure that they are safe, they're not developing adverse effects. We also give them a stipend for transportation and for them to look after themselves and take their medication so they don't drop out the study. So this study is being done across the world, UK, America, Brazil, Belgium, Ghana, and guess what? Also Nigeria now. So I won't bore you with this long summary, but essentially we found out that kidney disease is more common in Black people. And this is most likely because of a mutation in our genes, which has left us vulnerable to kidney disease. Now we're working on a drug that possibly could reverse the effects of this mutation and make our kidneys safer. Once patients in Nigeria develop kidney disease or severe renal impairment, the chances of survival, the 2-year chance of survival is at 24%. So this is a good step towards keeping Nigerians and Black people alive. So I would like to end with this slide. This slide just shows kidney disease and how we stage kidney disease. So people who are in the green have normal kidney function, and people who are in the yellow have mild renal impairment, and people who are in the orange have moderate renal impairment, and those who are in the red have severe renal impairment. So what we're trying to do with this drug is try to keep people in the red and keep them in the orange or yellow and at best green. Thank you so much. These are my references, and I'll be taking questions at this point.